Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. There are all kinds of cancers that develop as the result of mutations in genes, and we're going to be talking about that tonight. There are regulation of cell growth and DNA repair. That's something that's involved as well. And not all mutations are necessarily the same. So we're talking about cancer and genetics and what's new in that entire world. There are scientific advances that are revolutionizing the approach to the genetic cancer risk, screening, prevention, and targeted therapy, all leading to very specialized medical treatment. And during this next hour, we have experts answering questions about what's new in cancer and genetics. We'll find out the latest treatment options, and stay with us because, as you know, this is a live show. You can give us a call at 881-0013. This evening's program is underwritten by Texas Oncology, El Paso Cancer Treatment Center. You can go ahead and sneeze and cough, because you're a real person. We also want to thank the El Paso Texas Tech Paulo Foster School of Medicine for providing some medical students who answer the telephones and get your questions our way. I'm Catherine Berg, and you're watching the El Paso Physician. Cold. I want to say thank you very much also to the El Paso County. Sorry, I wasn't sure if we were on or not. The red light came on, so I thought that we were. But I want to say thank you very much to the El Paso County Medical Society, who has been producing the show and putting it together for over 22 years, almost 23 years now. And again, we have a beautiful program tonight that really talks about the curiosities of what's been happening in the last decade or more of really doing genetic testing and different ailments. Tonight we're going to talk specifically about oncology and cancer, but we have with us Dr. Regine Rivera, who's an oncologist and hematologist. We also have Nydia. This is not Nydia, this is Chris. I have my wrong script. Chris, tell me your last name.
Duran.
Chris Duran, who is?
Christina Duran.
Christina. Are you Christina?
Christina.
Okay, I'm going to call you Christina throughout the evening then. And you are a specialist that it's like you're the program manager. You get the costs, you know
Absolutely.
what questions to ask and am I covered? So we're going to have a lot of questions there. Usually it's all docs. Don't be afraid. It's all great. And if we don't know the answer, we'll get to it later. And then we have Dr. Nando Gopalan, who has been with us several times. And thank you so much for being here. This evening, again, talking about cancer, genetics. I would love for the three of you to kind of go through. I know that I always look at you as the gene doc when we've got some kind of an oncology show on. But if you can explain to the audience your interest in what you do all day, every day, but your specific interest in genetics, and it has been. I mean, every time we've done a show for the last 20 years, you've kind of always talked about, hey, but if your mom or your dad, but removed and not removed, explain to the audience your specialty.
Well, I'm a medical oncologist by training and became interested I've always been interested in genetics, but became interested more so about 5 years ago. And all of us at this table, plus also Nydia, which couldn't be here tonight, all of us are certified in risk cancer assessment, through genetic testing. And I think it's important to recognize all cancers have mutations in them.
Right.
And I'm going to say right now, mutations, the geneticist, they don't like that word because it implies that, we're science fiction, and it's all bad. No, not necessarily. I mean, mutations are just variations. So they actually prefer that we say variations. So if I say variations, mutations, kind of saying the same thing. And we know that all cancers have variations in it. That's what makes it a cancer. But not all cancers are inherited with a genetic predisposition. So you develop those variations or mutations because of environmental exposure, sun,
A lot of
what
which
you
we don't
eat,
know.
age.
Right. Age.
That's right.
The highest risk for any kind of cancer is age.
Absolutely.
Right? I hear that every single time
Absolutely.
we're on here. Christina, so with you, your specialty, think about people who may have questions of you. When people ask you questions at the office, at work, what is it that you specialize in so that people from the audience kind of can see what questions ask of you?
Well, a lot of patients come in and they want to know, do I do I have a mutation, or is there something that in my family, that is this cancer coming from there, or is it coming from the environment? But it's mostly, it runs in my family. So I kind of prepare the patient, and I tell them, well, you need to make an appointment. You need to discuss this, because a lot of insurance companies require that you have a discussion with somebody who's knowledgeable about it. Once that happens, they say, well, is this going to cost me a lot?
Right.
And so a lot of times it depends on your insurance. They require, a lot of insurance require that you have a conference with somebody that is knowledgeable in genetics. And then once that they decide, you know, this is okay, we can proceed to the next step, then they do we'll do genetic testing.
See, that's going to be fun to talk about throughout the night, because there are, and we were just talking earlier too, there are very basic tests like the 23andMe's that are kind of hip, the thing to do, but kind of be careful where we're going with that. There are very more specific things to look at. So some of the questions from the audience may have to do with that. So I just feel like in past shows that's going to come up.
Yeah.
Dr. Gopalan, hi.
Hello.
Thanks for coming this evening. So I guess I'm going to ask you a lot of the gene questions. I'm going to ask you a lot of gene questions too. The world of oncology. I know you kind of have the same title as Dr. Rivera, but in this world, what is it that you like to specialize in regarding what we're going to be talking about this evening?
I'm not sure.
Oh, it's a full
I
question,
think-
right?
I
Or I
think
could do the what do you do all
gene
day,
is
every day
probably when
question.
I talk
Yeah.
much about breast and ovarian cancer syndrome, so I will talk about Lynch and other syndromes if there is any
See,
question.
that's a good point, because I think too, when we first started talking about genes, I think for a while it was just breast, and then it started going to female cancers, and then you're looking at colon cancers, which is everybody. So that kind of is a nice evolution too of what things were maybe 7-8 years ago, and now all the things that we can start testing for. So Dr. Rivera, let's start with that question that you said earlier before we went on the air of simply what are genes? When we say our DNA, what is it that we, the medical community, I should say, what are you looking for? You were talking about variations. You're talking about not the word mutations, but there's BRCA1, there's BRCA2. What does all that mean if there's a way to kind of combine
we
that?
have thousands of genes in our body. And a gene, the way I explain it, is a gene is like a blueprint. So think of it this way. It's a blueprint for a cell to make proteins, and these proteins, of course, are going to affect cell function. If something goes wrong with the development of that protein, that gene may not work. So you talked about DNA. What if that gene is responsible for making a protein so that if something goes wrong with that DNA, they can repair it? Well, if it doesn't do its job, that DNA doesn't get repaired, and that can lead to mistakes. And so there's many things that a gene will do.
Now you say repairing it, the gene in its own self body, no help from you guys, no help from the outside. The gene just in your body
A
knows
gene,
it needs to repair
we have
the
thousands of
situation.
genes,
Right.
and each of these genes have different functions. And for example, the BRCA gene is involved in DNA repair.
Right.
And so if you have a defective BRCA gene, that particular gene may not be able to do its job, which is to
Gotcha.
repair our genetic material.
Gotcha.
It's important to keep in mind that what are mutations or variations, everyone here looks different. And we're different because of variations. So just because I find something doesn't mean it's necessarily bad. Otherwise we'd be all identical,
Right.
we'd look just the same. We know that even identical twins are a little bit different because of what environment and maybe other things. So I think it's important to keep in mind that, you know, genetics is really the study of inheritance and the variability of inheritance.
It's always fascinated me too. My biological father is an identical twin. And so one died very early with diabetes, the other one doesn't even have diabetes. So to me it's always been interesting how, if you have the exact same genetic makeup, as you said, what did they do when they were 2 or 3 or 4 or 5 or 6 years old, and where does the change start happening? There's no answer. It's just been fascinating to me all my life just because I have that in my family. Christina, So you were talking about when people come to you, and let's kind of go to step number one, that there is someone whose mother was diagnosed with breast cancer at the age of 50. So this is the person who's maybe 35 right now, and they're kind of curious. It's like, well, should I get tested? They call you. From there, take us through what it is that you're guiding this person to do or not to do. So let's say again, her mother was diagnosed at 50 with breast cancer. I don't know what kind, we can make one up. But just in general, how do you guide that person on the phone?
Well, then you start to tell them, is there more family history? Is there more people in the family, grandma, grandpas, cousins, brothers and sisters? So you start to ask them, you know, and then you go from that to maybe getting tested. We'll do what we call a pedigree, and we kind of see where they land. And so a lot of times, you know, that you could see a pattern. You start to see a nice pattern, and so then and then that's when you proceed to go into testing and stuff.
Okay. And when you say proceed to go into testing, what would be the first test? Is it saliva test? Is there a certain point where, okay, you've got positives here, let's go into the next test? Explain how that would work.
We can do either one.
Okay.
We do blood most of the time,
Okay.
but we can do either one. We can do saliva, we can do blood. That's okay.
Okay.
Either one is perfectly fine.
Okay. And when they,
Except for when they have to do RNA, then we have to have blood. And that's a totally different testing.
Dr.
So,
Rivera.
yeah, it's important. I mean, you know, there's so many. You've presented a 50-year-old, well, a 35-year-old whose mother is 50.
And the reason I said that is that mother is relatively young.
So the first question you're
have-
going to ask is, your mother still alive?
Right. Good
So
point.
let's pretend that Mama has, you know, has the 35-year-old, but has 4 other daughters. So what if you test the 35-year-old and she's negative?
Right.
You haven't said anything about the other sisters. So what you may want to do is test Mama, and then that gives you an answer regarding all 4 daughters, or however. And you've got to pick the right person for the testing. You've got to pick, you know, do you need more than one? What if you have Mama and Daddy both with different types of cancer coming into the family?
Right.
And you've got to take that. And then Chris will tell you, one of the hardest things is to decide, what test are you going to order?
Right.
Are you just going to order BRCA?
Exactly.
Are you going to order?
That's exactly where I was going with that.
That's right.
And on that note, and Christina, I'll ask you this because again, you're the money girl, which means who pays for the genetic testing?
Yeah.
Big question. I mean, that's what the audience members want to know,
Well,
right? It's like, okay, I do have cancer in my family. Mom has this, dad has that. I'd really like to see what's going on with me because they had different types of cancers. Where do they go from there?
Well, we like to test the person that actually has
Exactly.
the cancer
Okay.
itself. That's who
Okay.
we want to go for.
And who pays for that?
And then, so that person, hopefully they have insurance. If not, you know, if they have insurance, depending on the type of insurance that they have, then you have to, you know, use their guidelines. And a lot of times they use Medicare guidelines. And so you have to prove that you've done the counseling, that you've done your pedigree, but always the person that, you know, that has the cancer itself.
Okay.
That's the one you want to test.
And that's the
you
most
use
important.
the
I'm glad that you
insurance.
said that. That's the most important. If, as you said, if that person is alive, test them and then test others. From
Exactly, and then the insurance company, that's a, you know, depending on their copay, they would have to pay a copay. And a lot of times we'll submit the specimen to the genetic company. They will call the the insurance company, and then they will usually discuss what their copay will be,
Right.
if there is any.
Well, isn't
Or
it
if they
beautiful that
met.
that's even something that insurance companies are looking at and covering now? Again, this was a very different
yeah.
discussion several years back, that it just wasn't on the table
10
yet.
years ago, they wouldn't cover it.
Yeah, and now, and even if you don't have the finances, the genetic companies will actually go out of their way to try to help you out.
Right.
Either they'll reduce the cost, or depending on your income, they will work with you on that too.
And there's something in it for them too, because they're trying to also perfect what it is that they're doing.
But they are always willing to work with you.
Yeah, that's good to know. That's good to know.
Tell them about the first degree for positive test.
Oh, and
This
a
is
lot of
really
times, if
cool.
you have the mutation itself, you have a certain amount of time to get that testing for free.
Of
With
all
certain
your
certain
first degree
companies.
relatives. So,
Really?
so let's say a mother has a BRCA mutation. Her daughters, her sons can be tested.
All for
Her
free.
sisters.
That makes
And
sense
that
to me.
and
Of
all
course.
free.
Yeah.
The counseling is not free because a lot of times if you're going to go through the insurance company,
Right,
that's not
right,
free.
right.
But the blood, the specimen, the testing, and all that is all free.
That makes sense to me because it's all in the world of research. You want to figure out how this works. It's like, clinical trials, but not. But you're learning as you go. So I think that's a beautiful thing. And
yeah.
again, that does kind of make sense to me. Dr. Gopalan, I know that we're talking about cancers. You had mentioned Lynch syndrome, and I feel like we never talk about that. What is it for those people that don't know? And when you're looking at genetic testing, how Lynch syndrome and maybe others as well, what types of abnormalities is gene testing good for that's not just oncological, if that makes sense?
So the Lynch syndrome have 5 different mutations, so 5 different genes. It's not a single gene mutations.
Okay.
So they compromise a similar cancer predisposition pattern. The most common cancer they get is colon cancer. They are unlike the familial adenomatous polyposis cases. Their polyps are much fewer, like rather 10 to 15, that's the number they get, not like, and so they present like normal people, like sporadic colon cancer people also, they also
Right.
get, but they have a slightly higher number of polyp development than the average person. So colon cancer is the most common cancer they have. They are also at risk of several other type of cancer, women especially endometrial cancer, that is the second most cancer. Then there is a strong possibility that ovarian cancer also increased risk is there. We are not sure about the breast. They still argue whether it is included or not. Then they have rare cancers like urothelial tumors from the kidney, brain tumors. So there are several other cancers are there. So, but those incidents are much less. So these genes, 5 genes identified, they are easy to test. One another way you can identify is you can test the tumor for these expression of these protein, whatever the gene express. If the protein is missing, then that's give you a warning sign that they may carry a mutation. So now I think the colon cancer, all the tumors are tested for this protein.
So I'm going to ask, in my head, it seems ignorant for me to ask this because I feel like I've been doing this a lot, and there are no screenings per se. Like when we're talking about colon cancer, there is the colonoscopy. And if at that time several polyps are found and removed, would it be prudent at that point to do some kind of testing, or would you have to wait, or would it be better to wait until the biopsies come back, et cetera? How would that play into, it's not screening really, but if it looks like there's someone that's, literally just turned 50, I've got to go get my first screening, and they've got 8 polyps.
So there are 3 major different type of polyps.
Okay.
The common adenomatous polyps, tubular Wilder's polyp. If you have frequently more than 5 every time you have colonoscopy, that's a warning sign. Then you should have genetic testing. You don't do the polyp assay. Then there are certain other type of like serrated polyps. They have a high risk for progression to colon cancer. So those are the patients you need to have screening early if they have several of those polyps.
Okay.
And then you also need to know if you are high risk for colon cancer, if you have hereditary condition,
Right.
You need to have colonoscopy. The Cologuard test is not approved yet.
I'm glad that you said that. So there's a lot of commercialism going on around that, commercialism, marketing, et cetera.
Yes.
You know what? You said yes, and you said it with fervor. So talk a little bit about that. Cologuard is out there. It's a helper maybe, but it's not it's not foolproof in any way, shape, or form. Take that however you want to take that. Because I feel like we talk about that a lot, but
mean,
it's like,
it
I'll
is-
just get that test.
It is a reasonably sensitive test. I mean, the
Right.
occult blood testing, what we had in the past, that was very insensitive. Only if you bleed, you pick up bleeding, and then there are several other reasons you can have bleeding. So you had to test for it, the colonoscopy. The Cologuard is different from the fecal occult blood. It's look for when you have tumor, they spill genes, degraded and spill, and that comes through the feces. So it look for those genetic markers.
And
So
that's-
it is sensitive enough to
Yeah.
identify. The problem is if it comes back positive, you need to go back and have a colonoscopy. So
Right, right. I just, literally a couple of days ago, I remember listening, 'cause I knew this show was coming up, and it said testing the DNA in the stool, which I
Right.
thought was interesting wording for Cologuard, which is different than what people used to call the smear test way back when. So
For looking for blood.
looking for blood,
Right,
yeah. So if
right.
there's no blood, but looking for the DNA in the stool, I thought that was interesting because I thought, okay, how much different is it than the smear test from 2 decades ago?
But you know, if you're considered high risk, you're
Then
not
do
going
it
to do
anyway.
that test.
Right, good point.
Because
an average risk person.
that's right. This is the average person.
Right.
Just
Nicely
like
said.
when we have guidelines and we discuss guidelines for the average population. If you have a history of colon cancer in your family or you have a personal history of colon polyps, I don't think I would do that.
Right. Go through and get the actual
That's right.
colonoscopy. The nice thing about a colonoscopy as well is when the doctor is in there, he removes the polyps, she removes the polyps, and if it happens to be cancerous, at least that polyp is now gone. You then go a little bit more often and get your colonoscopy, but that's always a preventative thing as well, not just a screening, but you're getting some stuff taken away from there. Dr. Rivera, I'd like to, because the BRCA genes, I always think that BRCA1, BRCA2, and BRCA is just basically breast cancer, but BRCA genes are now, again, more female. When I say more female, it used to be called breast cancer, BRCA. And that's how I used to have it in my head. So I thought to myself, well, it's only looking for breast cancer. It's not.
In fact, actually, there's a new name now, and so instead of calling it the breast cancer ovarian syndrome, it's breast cancer, ovarian, and pancreatic. And so
Okay.
we were talking, you know, before about new guidelines that are coming out. Other cancers are being added into this. So you can have a family that, let's say, has a lot of prostate cancer. Certain types of prostate cancer in young patients, prostate cancer that is biologically aggressive, meaning that it has a Gleason score of 7, okay, or more. People that have metastatic prostate cancer. These are individuals that you should consider. I'm not saying you have to, but you should consider for genetic testing. And believe it or not, the BRCA gene is one of the major causes of prostate cancer in younger individuals or biologically more aggressive. So the same thing goes for pancreatic. So now guidelines are not only, hey, mama had breast cancer, now it's mama had pancreatic cancer.
Interesting.
Daddy had prostate cancer that he died of at age 55, and now I have breast cancer. So let's say I'm a 60-year-old woman, and
Right.
I have a breast cancer, and daddy died of a young prostate cancer, and somebody else in the family had a breast cancer maybe at age 50. They have criteria for doing the testing just based on the prostate.
And that's nice too, because there are so many different things that people can start looking for. I'm just going to acknowledge you, obviously I'm handing over a note to the production staff. So when we're looking at I feel like pancreatic cancer is one of those very difficult cancers.
Oh, yeah.
Once it's diagnosed, there are very few, if any, symptoms. Is that right? I mean, I don't know if there are any symptoms for pancreatic cancer. When someone is diagnosed with pancreatic cancer, how is that diagnosis usually done? Like, what symptoms would there be, or why would somebody go, oh, you came in and you happen to have pancreatic cancer? I feel like that, it's a toughie.
Well, any oncologist will tell you by the time the patient presents to you with
Exactly,
symptoms,
yeah.
it's usually quite advanced.
Yeah.
Now, not always, but
Okay.
it usually is. And again, let's remember that we're talking about exocrine, or you're talking about a certain type of pancreatic cancer, the most common type.
Okay.
Not like the small cell pancreatic cancer. We're talking about, well, that's what Steve Jobs had. What we're talking about are a certain type, the garden variety, we'll say pancreatic cancer.
Okay.
And I think it's important to understand that when we screen, just like in breast, you want to pick something up early so that you could go in and operate and take it out and, quote, cure the patient, right?
Right.
It's hard to pick up pancreatic
Right.
cancer early unless you do relatively expensive and somewhat difficult diagnostic test.
So when we were talking earlier about genetics, if there was someone in your family, and this goes where generationally removed, mom had pancreatic cancer, so yeah, you definitely want to check. But let's say, you know, great uncle, you know, 2 generations ago, I guess what I'm asking, this is so hard when it comes to genetic testing because we don't want everybody to go out there and just get tested and spend the money if there's not a real reason to. Breast cancer, that's something that there's a screening for. Prostate cancer, there's a screening for it. Colon cancer, there's a screening for it. Pancreatic cancer, there isn't.
Well, there is, but it's not. It's
Tell me.
hard to do.
Okay. And expensive.
And expensive.
Yeah,
And
yeah.
you and I both know that insurance.
And the normal person would not do that versus the other screenings
Absolutely.
I'm talking about.
It's going to be an MRI of the pancreas. The moment I say MRI, insurance companies, you know, start to shake and quake, and you're going to have. And then there you're talking about endoscopic ultrasounds. So you're talking about going through and looking at the pancreas through the stomach with a little camera.
Right.
I'm sure the GI doctors are probably cringing at my description. but I think
But
it's,
everybody else can understand that. and that's
but I
good.
think it's important to note that it's not just breast, it's not just ovary, it's not just colon. You know, Dr. Gopalan mentioned that the Lynch syndrome, you have a young woman with endometrial cancer. You should think of Lynch syndrome.
Interesting.
Ovarian
Right, okay.
cancer, we test all ovarian cancers. We test all male breast cancers, and we're beginning to test all pancreatic cancers, again, within reason. So you gave the example of what if my remote second or third cousin had pancreatic, I've got a big family, no one
Right.
else has cancer. Well, then you're taking things into consideration. That second cousin also has relatives that you're not related to, in-laws.
Right.
So you have to, what Chris said about doing these 3-generation pedigrees and trying to get an idea of what's going on in this family. No one should overreact to an isolated cancer unless, you know, there's certain things like an ovarian.
Okay. Christina, I want to start asking you some questions here because I have a question here about symptoms, and this is hard again because it's about testing. It's like, depending on what kind of symptoms do we have, when do we know when to go get tested? So what I want to do is debunk this question, I guess, of it's not about symptoms and then getting genetic testing. It's about the people ahead of you generationally that get tested to see where you are. So the question really is, how long does a cancerous gene start showing symptoms before it's time to go get screened? I know it's very generic. There's not really an answer to that. But I can see why this person is asking the question. It's just that there isn't, unless I'm wrong, there isn't a
I can
real.
answer
Yes,
that
by
question.
all means,
So
Dr.
simply, I
Gopal.
mean, so now we have 116 and counting gene mutations. So we are getting to know more and more mutations.
116.
Right now we
Gene
have
muta-
116.
okay.
So and then we categorize them into high risk, moderate risk,
Okay.
and low risk. Take for an example, if you take BRCA1 or Lynch syndrome, any of the 5 Lynch syndrome genes. If it is a BRCA1, you have a lifetime risk of having cancer, breast cancer, 60%. So that progressively goes up. So, so you start screening early, 25 years, you start
Gotcha.
MRI, and likewise in the Lynch syndrome, they start early. So they have a tendency to present cancer at a young age. So you start screening early. So Lynch syndrome start colonoscopy at the age of 40 and then repeat it every 2 to 3 years, not every 10 years.
Right.
And then you have these moderate risk genes. There are several of them. There we don't have a clear idea because not enough studies to look at what are the screening guidelines. then we have the low risk genes, they are treated like general population. But when you go for cancer testing, you're going to have a panel including all of these risk genes. So we do get patients with moderate risk gene positivity, and if they have a very high tendency to have cancer in their family, you treat them like high risk.
Right. Nicely
Especially
said.
like CHEK2 in breast and
Yeah. And Christina, you're nodding your head really hard on that. So, which
yeah.
makes me think that you've got something else going on in your head too. Do you have anything to add to that?
No,
Okay.
no, just
so the other thing is when if they didn't have a genetic test mutation, testing done, if they have a family history of cancer, 10 years younger is probably the best time to start screening.
10 years younger than that
The
person
youngest
was
person
when
had
they started,
diagnosed,
when
yeah.
they were diagnosed with their cancer.
Remember,
Okay.
not all mutations are the same.
Right,
You know this.
right.
I mean, you can have, well, we'll use, for example, the CHEK gene, which is, they found this gene because it's sort of around the BRCA genes. They looked at all the, quote, we'll call them helper genes around BRCA. And they began to find out that families that were BRCA negative had mutations in these other genes,
Interesting.
of which
Okay.
CHEK was one.
Okay.
Well, the CHEK2 gene, the original description was where part of the gene had just kind of been deleted.
And this is a person with current cancer.
No, it can
No.
be. It can be a patient that came in because mother died of breast cancer.
I see.
So
Okay,
we're doing.
okay.
So we're doing panel testing. We're looking at genes that address the cancers within this family.
Okay.
So let's say you have colon, and let's say you have breast. You might want to include the colon genes along with the breast genes because there is a little bit of an overlap. But let's getting back to CHEK. We know that certain CHEK genes have a higher chance of having cancer, especially if there's a family history of breast
Right,
cancer,
right.
as opposed to some genes where the risk may only be twice that of normal. And I think that's important, and that's where, you know, not all things are the same. There's a rare gene called NBN that now, and we've seen several of these, it's rare, but they're now saying probably the most important thing about this is that there's really one mutation that has been related to an increase in breast. So maybe the other ones, you know how we talked about variations, maybe if they're not as important, maybe the risk is really not much more than the general population. Again, more work needs to be done on this.
Right, right.
Yeah.
And see, this, of all the shows that we do here on the air, this is the one that I find that really is so fascinating because things can change in a couple of months
Oh,
on
they
what's
do.
being done. You said 116, and I was just reading up on this too, of all the genes, how beautifully our bodies are made, right? In trying to help heal ourselves. So whatever being you believe in, thanks for that. Because you're talking about the variations in the genes, and then your own genes, your own DNA trying to fight the bad guys, and that's going on all day, every day in our bodies, and we just take it for granted. You know, if you're able to find the genes that are doing better than the other ones, and there's the whole, you know, gene therapy that's out there, which is a whole, it's kind of in this topic, but not really.
Who knows? Maybe we'll be able to cure sickle cell disease because we know right where that little, you know, abnormality is, and can you go in there and replace that? I mean, that's the hope. Right now, there are patients that have very severe hematological problems like sickle cell that they're candidates for transplant. Now, I mean, I don't know what the criteria are for sickle cell getting transplants,
So-
but they actually will do that.
What would you transplant? The bone marrow?
Yes, and they'll have
Okay.
from someone else that has a
Someone else.
normal, and they'll make normal hemoglobin. Now, remember, bone marrow transplants,
No, I know. I get you. That's a big deal, and that's
Oh,
why I was asking.
people die
And-
of bone marrow transplants.
Yes,
so,
exactly.
yeah.
So
the
Dr.
question
Gopal?
you're asking is, can we go and edit these mutations?
Right.
Good
So
question.
that is a hot topic now. Remember, the Chinese doctor got into trouble prematurely doing the editing.
Right.
So there are issues with that. I mean, yes, it is a technology evolving at this time, and then yes, if we have a specific mutation, there is a possibility we will have that tool at some point. Then the story comes up like in Gattaca. Do we gonna have a world like that? I don't know. Possibly.
Right. Yeah, it is. You do kind of border on
Yeah.
science fiction here, or science. I should take the fiction word out.
Yeah.
Just science advances, and where we're going to
It's
be 100 years
coming.
from now.
We're going to, less than 100 years. So you're going to have a child that's born, and that child is going to have a genetic profile, not just for cancer, for diabetes, hypertension, heart disease, dementia, right? And that child will be given, you have, let's say by age 50, a 20% chance of being an insulin-dependent diabetic. Okay, so one, can you correct it? But two, could you change your lifestyle
Bingo.
to delay it? So that there's two things, you know, messing with our genes can be potentially hazardous. And then what if, like in the science fiction movie Galactica, what if you decide, parents say, well, I want a child that has a strong heart and is smart and has green eyes, or you know, you can make all sorts
you
of
start
scenarios.
borderlining on a lot of issues.
That's
there.
right, and that movie teaches you that it's not all genetics, because the person that wins out in the end is not the super child. Oh, I
Right.
shouldn't have told the end, sorry.
So, we also have another mode of selection. In case a person have a BRCA mutation, they can elect to have pre-implantation testing. What do? Is
Yes.
they do the embryos and test the embryos for the mutation and identify the one without the mutation and implant. So that way you can avoid the transmission of the gene, what you carry.
Right.
So that option is available now.
See, it seems, I don't know, I can see a lot of controversy around this in many worlds, but if you're looking at strict science, it is phenomenally interesting on what my kids are going to experience. I've got a 22-year-old and a 17-year-old. Eventually, they're going to have babies. You know, I'm going to be grandma and I'll, you know, maybe they'll know a lot of information. My mother died 25 years ago. My mother died of lung cancer. Yes, hers was small cell lung cancer, which really kind of means it was a smoking cancer. So for me, I haven't been interested in doing any kind of testing because that was such a specific environmental type of a cancer. But you know, if I get something, I don't know. There's so many questions that I have. There's a question here from the audience, however. If there is a cancer that goes into remission, is there a way that genetically you can detect that type of cancer? So let's say someone had a certain type of breast cancer. We don't know yet because they have not been tested. They're in remission, and let's just say they've been in remission 10 years. Let's just say that there's been that 10-year remission. So they're going to get tested because, yeah, at one time they did have cancer, but they don't anymore. Would they still have that mutation or that variation, so that when they get that test, their kids would be able to know some information about them?
Well, sure. I mean, many patients with genetic mutations like BRCA can be cured of their cancer and go on and live a normal life. But they don't get rid of that gene.
Right.
And they can pass it on to their children, and their
Okay.
children can have it. So I don't know if this woman is asking, or I assume it's a woman, but I don't know if they're asking, does that mean that I can do a genetic test and it can tell me if my cancer is going to come back?
That's
The answer
exactly
is
the question, actually.
the-
Is there
the-
any way to find out if the cancer can come back?
Well, the answer is no. I
Okay.
mean, if you're a BRCA patient and you have had a breast cancer on one side of and you still have breast tissue, you are more likely, just because you've had cancer, but also because you've had cancer and the BRCA gene, to get another cancer. So that has led to some women, and it's not, you know, an absolute, but some women then say, I'm going to get rid of my breast tissue.
Right.
So that cuts it's not 100%, but it cuts your risk of breast cancer down significantly. Some cancers like ovarian, we can't screen for, not well.
Yeah.
So that's why with many BRCA patients, they will say, let's take out the ovaries, let's take out the tubes, and we can reduce your risk of ovarian and tubular cancer. Again, not 100%,
No, but enough to where it would make a
substantially
difference.
where this may be very important to you. And that's discussed with all, you know, you've got to wait till they're through with having children and
Right.
other things.
Right.
I mean,
How-
there
Dr.
is,
Gopalin?
it's going to be available at some point. I thought I saw a study recently. Whenever you have tumors, they have these several mutations in the tumor. That is not the one you genetically carry. This is something happened in the tumor. And then they release them into the blood. So we have a tumor DNA testing, circulating DNA testing available. The study was, I forget which cancer was, they were able to test to see serially these specific circulating DNA in the blood. And the patients who showed up the circulating DNA, they had a chance of high risk of tumor coming back or metastatic disease.
Right, right.
So it's in the primitive stage now.
Okay.
But you know, but what's interesting, what he's describing, not everybody. So you have these cancer cells. Well, we think they're cancer cells. Remember, sometimes when they look at cells, they say they're cancer cells, but it depends upon your test. And having, sometimes they just identify cells that they think are cancer, but are not. But anyway, not everybody that has these cells will get cancer.
Exactly.
So,
And
right.
that's
so
the big, you know, again, not to fearmonger, and I think
Yeah,
that's a
yeah.
big thing. I always want to be careful when we talk about genetics on this program, is that it's not, you don't want to instill fear in people. It's like, oh my gosh, I do have this variation in the gene. Does that mean I'm going to get cancer? We don't know. You know a little, like you said, there could be a variation in lifestyle, maybe get checked a little bit earlier, more often, et cetera,
Sure, sure.
because everybody is so incredibly different on that. I want to see where you got, we have so many places that we can go. We have about 20 minutes, and there are so many places that we can go. I'd rather stop here and ask Dr. Rivera where you'd like to go for the rest of the program, and Dr. Gopalan as well. And Christine, I'm going to have you fill in some of the gaps there, because we could talk 15 hours on genetic testing. I feel like we've talked a lot about breast over the years. What in your thought process or in your experience over the last couple of years are you really excited about?
Well, I'm excited that they're beginning to recognize that pancreatic cancer should be screened.
Nice.
That
I agree
prostate
with you.
cancers need to be screened. No, we are not talking about a low-grade prostate cancer in an elderly gentleman. We are not talking about that. We are talking about the 50-year-old that has metastatic prostate cancer. You may not find anything now, but things are going to change.
Right.
So it's not just breast or ovary, it's uterine, it's other GI tumors. What about stomach tumors? What about skin cancers? Melanoma comes into this. So it's a combination of cancers. We don't know a lot about lymphomas or leukemias. Yeah, there's some genetic mutations that have been associated with families, but they're very rare. So why do we see families that have lots of leukemias and lymphomas? Could it be just environment? Maybe.
Depending on if
so
the
that's
family's
the
all
way
living
that
in the
genetics
same
going.
place.
And then, you know, we used to say we'll do a BRCA test, and that was it.
I remember that.
Well, there's a lot of genes, as we just have been saying, that can be associated with breast. Dr. Gopalan alluded to the fact that we're beginning to see a couple of the colon, the Lynch genes, that there's a hint that there may be a risk in breast cancer. And people have wondered for years, people that have, let's say, BRCA, do they have an increased risk of endometrial cancer? Still not all the answers are there. What about colon? You occasionally see it. So, you know, is it just a chance occurrence? So there's lots of other issues that go into this. And so it's expanding.
Christina, with what Dr. Rivera was saying, and again, in your role and talking with patients, I know you talk with patients too, but you've got this head this big of research and things going on in there.
No.
So what might you suggest are some of the questions the audience might be thinking right now? And it's kind of the same question I said at the beginning of the show, but now that we've got a little bit of context behind us, with what we've been talking about, what do you think patients are thinking? Okay, well, I've got Christine on the phone. I'm talking to her right now. The questions that I have are, what would you say at this point?
What are they asking?
What are they asking you? Yeah, after what we've been
A lot of
discussing in
times,
the last 40 minutes.
as soon as I see the patients, they're all kind of, I have a lot of cancer in the family. And then when you start interviewing them and stuff, and then you start looking at the patterns, some patients are coming over for treatments. Some of the genes are being used, like for BRCA, for certain treatments are for that. Colon and all that. So
stop there. Explain to me what you're talking about.
Okay.
So they're being used. The
So
genes.
BRCA genes for
BRCA
PARP inhibitors. Now, it's not being used in early stage, but if you have an advanced BRCA or an an advanced breast cancer patient with a BRCA mutation,
Right.
or an ovarian malignancy with a BRCA mutation, there are drugs directed at this defect that can help the patient. For the Lynch syndromes, patients that have what we call MSI high, immunotherapy appears to be quite effective. So there are hints that the actual mutation may be a window into treatment. Right? Can you think of any others? Any others right now? I was just trying to.
Melanoma?
MSI and this is what
MSI
tumors,
mainly.
BRCA1.
Yeah.
And they're using this. So a lot of times I have to interview the patient and say, well, why are you here?
Right,
And
exactly.
so because that way I know exactly where to direct my care.
Exact.
Okay.
Once they're there. Also to instruct them, what can you do to prevent? Prevention is another one. What if you're negative, you just still have all this family. I'm there. My role is to instruct them. This
Okay.
is what you're going to need to do in the future.
And if they are negative after being tested, it's not just go away and just, you're still looking at watchful waiting as a word that we've used
Well,
for so many
yes.
years, but you're still cognizant of the idea that your ancestors, your generations do have this issue.
Yeah, there's something there. We just don't know what it was. Maybe it was environment. Maybe it was genetic. We don't know.
And 3 years from now, that could be something come back and go, okay, you know what, now we know how to test for A, B, and C.
And then the other thing is having certain mutations come back as variants. We haven't really talked about that. I have to keep a lookout on those. They come through. Have they become pathogenic now? Because
Okay, so there could be
s-
mutations that they found with the testing, and they are dormant, for the lack of a better word.
They
And
call them
then-
of unknown significance.
Significance.
We don't know
Okay.
what this
Why.
means. Because
Okay.
remember, we talk about blueprints. So is this particular variation in the really important part of that blueprint?
Gotcha.
So
Or
you
is
look
it-
at the family.
That's
Okay.
right. And you make recommendations based on the family, personal history, but you're going to follow those. That's why it's important to go to, and I'm going to have an aside, we have some very good genetic companies here in the United States. It's important to go to a company that will follow these. To just report it out and say, okay, I'm through, I don't want to do
Right.
this anymore.
But a lot of them are, following them.
Absolutely.
So, and they actually will call or report it some way or another. I'll receive notice, and then that's my role in order to call that patient back.
Okay.
That's why we tell patients, go ahead and call us back in a couple of years, to see if there's any new information out there, because things are changing constantly and very, very fast.
Yeah,
So
we had
my-
one that was just changed.
Okay.
We had to bring 5 patients back. One had been out 4.5 years.
Oh my
and
gosh,
say,
okay.
we initially told you this. We didn't know at the time that it was
Right.
important, but we base recommendations. Guess what? The companies, not just one, thinks that this is an important mutation. Therefore, we think you should test other family members for this. It's because we have guidelines.
Right. So my question, I'm sitting on the couch right now, and we're saying there are really good companies and other ones that are just companies. My question is, how do I know which one's the really good companies? So do they call someone like Christina and say, who are you guys using? Or would you just naturally know that and because one of the questions here is, does a genetic testing have to be ordered by a doctor? Well, I guess not. However, if it's not, you're kind of taking your chances of what company's being used. I guess that's where my question's coming in.
you really need the
How do you know?
counseling.
You need the counseling, and you need really a medical individual that knows which companies are good. Do you understand where I'm going with this question?
There are some companies that will take what we call direct consumer requests. So I'm a woman, my mother died of breast cancer at 35 years old. I know I need genetic testing, or I think I need it. These companies, the reputable ones, will have you talk to a genetic counselor on their staff. That counselor will take a history, will do the pedigree like Chris does, and then will say, I think you need testing, this is what we can do for you. So they do, there are direct consumer testing that is being done. You're still getting counseling, only you're
Right.
getting it over the phone, but that's not so bad.
Right.
It's better than no counseling at all.
Yeah, and I'm still thinking, how do you know who to choose? And that's not a question for this panel. I get it.
Nowadays,
Dr. Gopal.
nowadays, the next generation sequencing, the machines, they are reasonably good. So all the laboratories, commercially available laboratories, tend to have the same technology.
Okay.
So the quality comes into play, how much database they have, and the laboratory director has to interpret. The interpretation carries a lot of value. So the labs which been there for a long time, who have a larger database, they tend to give you a better interpretation. Like some of the lab, I think they don't even give an interpretation, so it falls upon the person who's
doctors
reading.
and-
Yeah.
right, right.
So that carries a lot of
Yeah.
skill
And,
involved. So
it's difficult to read those when they don't have those interpretations.
And the
Very difficult.
interpretation is, for the most part, done by the genetic company that is.
yes, the
okay.
laboratory director
Okay,
has
so
to
they've
do
got
that.
someone on staff, and by the time it gets to you three,
So they
there's-
go through the whole literature and
Okay.
find out what is present, what happened. So and
like the
then
radiologist will say, this is what I see on the mammogram. The genetic company will say, this is what we see in the genetic
And then
testing.
we also still have to interpret that too, because then we still have to explain it to the patient.
Exactly.
In nice words, you know, where,
So usually-
where
Nice
they.
words. We need to explain it to the patient in nice words.
It's very complicated.
It's very complicated.
I'm sure it is. I'm sure it is.
And you don't want to frighten them. You know, we sometimes see people that have more than one variation. Some of them may be not so bad, or we don't know what they mean, and some may be, in fact, what we call pathogenic. So it's important not to, you know, not to have them so overwhelmed.
Right.
And you know, you'll mention these little variations, and they'll say, "Oh my God, I
Yeah,
have
they
a
start freaking
variation in a BRCA." Well, no, they don't really think that this is, you know, clinically significant, but we're going to follow it. And chances are we're going to make recommendations that, you know, are not far off from what we would recommend if you were positive.
Exactly. I'm reading some of these questions here from the audience because I know. So I'm reading this one cold. A caller has a MTHFR mutation. APS, history of polyps is my risk for developing colon cancer higher because of these mutations. Dr. Gopalan, I'm throwing that your way.
Yeah, you do that.
So yeah, sorry, that's a methyl tetrahydrofolate reductase mutation. It has the major association is if we have both genes affected, you have a higher risk of. This is a folic acid pathway gene. They have a high risk of miscarriages. In hematology, in our practice, if they have both genes affected, and then they have a high risk of having blood clots, cardiovascular disease, or cerebral accidents. So that has nothing to do with polyps. So those are specific mutation. And then what was the second part you said?
The second part, APS, history of polyps is my risk for developing colon cancer higher because of these mutations. So it's MTHFR mutation and then APS.
Adenomatous
I don't know
polyposis
what that
syndrome. That's a familial adenomatous polyposis, APS. So
Oh, yeah.
if he
Okay.
has that, that puts it at risk of colon cancer.
Okay. So this guy needs
This
to
is the
take that
patient.
question to
Yeah.
General
Yeah,
Docking.
and there.
But then you
I
also
wonder
had
if
to
he's
find
saying-
out where was it done. I mean, who did that testing? So I mean, if it was like probably from one of these commercial direct-to-consumer lab, they need to retest it.
Nicely said, with specific questions
Specific.
in mind, I'd imagine. Yes.
There is a, and Dr. Gopal knows this, there's an MUITH that is a mutation that has been associated with polyps, but it's also recessive, meaning you've got to have
Both
from
genes.
both
Both
mom and dad. And but what he was saying,
APS means a dominant gene, so
Yeah,
that
that's a
need to be
dominant
checked
gene.
out. He
Yeah.
needs to see somebody who have training in that field.
Okay.
that's not a good mutation.
No.
If you live long enough and you haven't done something to your colon, you will get colon cancer.
100%
Yeah.
colon
100%.
cancer.
Okay, go. Whoever called in with that question, go check it out. Like tomorrow, make the phone call.
Yeah.
Write yourself a note tonight, put it on the icebox.
I'm
So every-
assuming APS mean adenomatous polyposis syndrome
Yeah.
gene, but I mean, people when they use abbreviations, they may make mistakes too. So
Right.
Yeah, so let's not panic our
Right,
viewers.
exactly.
The other thing too is some genes, like APS, can develop de novo. So you may have a family, no history, and all of a sudden, boom.
Right.
There's someone that comes in, you do a colonoscopy, and they have thousands of polyps.
Jeez.
So you test them, they do in fact have the mutation, no one else in the family has it. So there are some genetic mutations that can be what we call de novo. It's rare except in a few mutations. You know, I don't think 20% or 30% of a de novo mutation is rare.
Right.
So I don't know what this young man has, but you know, you need to talk to somebody.
Yeah. No, I agree. I absolutely agree.
A gastroenterologist
It's-
would be able to tell you about that.
There you go.
Yeah, I
Yeah.
mean,
Okay.
yeah.
I want to start wrapping up. We have something a little bit special this evening for the rest of our. Oh, no. Keep going. I love that. No. Keep going. Okay, but we do have something special for you before we wrap up. So do know that. And what it is, it's kind of a behind the scenes look at some things. So on that note, I have another question here, and I don't know how to answer this, but I'm throw it out as a respect to the audience members. My husband's family has a lot of cancer. 4 out of 12 siblings have had it. Doesn't say what kind, doesn't say what age, anything. Question is, should he and the rest of his family get genetic testing? This is that question. Not he and his family, but the 4 siblings that have had the cancer would be the ones to get tested. Is that right?
Ideally, yes. I mean,
Okay.
Or if
They
our
need to talk to
grandma
their
and grandpa's
physicians.
still alive.
Or if grandma and grandpa are still alive.
because
There you go, because
if you
it
have a
filters
genetic
down.
mutation, most of them are going to be coming from mama or daddy, and that's who you test. If they're not alive, you can't do that. And then you test the people with the cancer.
Right.
And then
that's
again,
the important thing.
what
You
type
have
of
to test
cancer
the people
is this?
with the cancer.
Are these all heavy smokers and they're all lung cancers?
Right.
Well, no, you're
Yeah.
not going to test.
Right. 4 out of 12 siblings. You're exactly right. I mean, we don't know which cancers those are. Question here from the audience too. Is it possible to genetically test pre-cancer or cancer cells to find out what symptoms they can cause? I don't see that being a thing, but again, I want to respect the questions that come our way. For example, precancerous cells in a patient's stomach causing bloating, hardening of the abdomen, etc. If we don't have a way of answering it, this is all that we have. This is the disclaimer that I usually give
We
like a
don't
half
have
an hour
any
ago.
means to test.
We don't have a lot of information on that.
That's not for genetic testing.
That's not, yeah, exactly. I did not give a shout out earlier to the people who have been collecting these questions. So I want to say once again, thank you so much to the medical students from the Paulo Foster School of Medicine who happen to be today, Nikita Lobo and Malini Riddle. Thank you so much, guys. Oh, look at how fancy you guys. Oh, there's one more question on the phone. It's like a telethon. We got to make sure that we get that in. But we want to say thank you so much because this is that time of the year when they start wrapping up the semester and they're still here volunteering. And again, Texas Oncology, those of us that are here know Texas Oncology is the El Paso Cancer Treatment Center. And again, we've had Dr. Rivera, Dr. Gopalan, and Christina Duran on this evening. And again, the fun thing that I have to show you, if you want to watch a show some other time, because there's a lot of information here, KCOSTV.org, and you can go to watch and then find programs. You can also go to the El Paso County Medical Society, and that URL is EPCMS, so just think of El Paso County Medical Society.com. You can go there. And so what we have for you before we really end the show is a happy end of the year and a little video of all the people that you don't get to see all day, every day when the show's going on. It's all the people behind the scenes that are making things happen. I have to say a big thank you to Mario and to Frank and to Oaxaca, which is his name. He's counting me down right now. We've got 6 seconds, 4 seconds, 3 seconds, 2 seconds to the video. Have a nice holiday season. I'm Catherine Berg.
That's what I need. This is what you have.
And I'll just say, is there something that we haven't talked about?
Macaroons.
Batería para conectar. ¿Ya sabes qué digamos?
I am setting up the lights, just some soft blue light.
Game burrito.